Welcome to the Explainer. Today, we're going to crack a clinical case that you'll see all the time, especially on your board exams: anemia of chronic disease. All right, so let's jump right into the big question, the paradox at the heart of this whole thing. How can a patient be anemic, not enough healthy red blood cells, but at the same time their iron stores are totally full? It sounds weird, right? But that contradiction is the classic sign of anemia of chronic disease.
So, right off the bat, you need to know this is not your run-of-the-mill anemia. We're not talking about simple blood loss here. Nope, this is anemia of chronic disease, or ACD for short. And trust me, it plays by a different set of rules.
And here's the textbook definition, but let's break it down. What really defines ACD are two key things. First, you've got some kind of underlying chronic illness. And second, this is the kicker, you see normal or even high levels of ferritin. And as you know, ferritin is our go-to marker for how much iron the body has stored away. Now, when you get the labs back, initially this is going to look like a normocytic anemia. And that's a huge buzzword for your exams, so circle that one in your notes. The red blood cells are the right size, there just aren't enough of them. But, and this is a tricky part, over time it can actually start to look like a microcytic anemia, where the cells get smaller. That's a super important point for your differential diagnosis. Okay, so what's really interesting here is that AFCD isn't just one thing. It's more like a family of anemias, and they all have slightly different root causes. First up, we have the most common type, the one you'll see the most. It's called anemia of inflammation. This is the classic ACD we think of, and it's driven by the body's own inflammatory response to things like IBD, rheumatoid arthritis, or even some cancers. Then there's number 2, anemia of organ failure. This one's a little different. Here, the problem is that the organs responsible for signaling red blood cell production, I'm looking at you kidneys with your erythropoietin, well, they're failing. So the signal to make more cells is just too weak.
And finally, we've got the anemia of older adults. This is something you might see in up to 20% of folks over 85. It's what we call a diagnosis of exclusion, which basically means we've ruled everything else out. It's really just a consequence of aging. The whole system just gets a bit less efficient, and the bone marrow doesn't respond to erythropoietin like it used to.
All right, let's zoom in on the real villain of the story, especially in that anemia of inflammation type. We need to talk about a hormone called hepcidin. Think of it as the gatekeeper, or maybe a better word is bouncer, for all the iron in your body.
So here's how it all goes down. You have a chronic disease, right? That causes inflammation, which tells the liver, hey, pump out more of this hormone hepcidin. And what does hepcidin do? It acts like a bouncer at an exclusive club. It goes to the cells where iron is stored, the macrophages, and locks the doors. It will not let the iron out, so the iron gets trapped inside. The end result? We call it iron-restricted erythropoiesis. Fancy term, but it just means you can't make red blood cells because the iron's on lockdown.
And this quote really says it all, doesn't it? The patient is iron replete. They have plenty of iron, but the iron is unavailable for erythropoiesis. It's there, but it's completely useless because it's locked away.
Okay, this next part is absolutely critical. This is probably the most high-yield comparison you need to nail down for your exams, telling the difference between anemia of chronic disease and its evil twin, iron deficiency anemia. If you get this wrong, your whole management plan will be off. So, let's look at this table. This is pure gold, but it can also trip you up. Now look closely. The serum iron is low in both conditions. That's a red herring. Don't fall for it. The real story is in the storage and transport proteins. See, in true iron deficiency, the body is desperate for iron, so it cranks our production of transferrin, that's the transport protein, to try and grab any iron it can find. That's why TIBC is high. But in ACD, the body is actively trying to hide the iron. It thinks there's an infection, so transferrin is normal or even low. It doesn't want to transport iron around. So, what's the one lab test that's going to be your tiebreaker? What's the key? It's ferritin. You have to burn this into your brain. In anemia of chronic disease, ferritin is normal or high because all the iron is locked in storage. But in true iron deficiency, the stores are empty, so ferritin is low. That's the ball game right there. And here's a fantastic little clinical pearl for you. If you see a ferritin level below 30, that is a huge red flag. Even if the patient has a chronic inflammatory disease, a ferritin that low tells you they almost certainly have a true iron deficiency happening at the same time.
All right, so we figured it out. We've solved the mystery of the trapped iron. Now what? How do we actually treat this?
Rule number 1, and this is the most important thing. You have to treat the underlying condition. The anemia isn't the disease itself, it's a symptom. You get the inflammation under control, and a lot of times, the anemia will start to fix itself.
But what if the anemia is really bad? If it's causing symptoms and really affecting the patient's quality of life? Well, then we have a couple of options. We can give them a red blood cell transfusion for a quick boost, or we can try to stimulate their body's own production with something called recombinant erythropoietin, or EPO. Now, you can't just give EPO to everyone. Its use is pretty specific. It's FDA approved for certain conditions like chronic kidney disease or rheumatoid arthritis. And typically, we only even consider it when the hemoglobin drops below 10.
And when we do use it, there's a target we're aiming for. We're not trying to get the hemoglobin all the way back to normal. The goal is to keep it in a safe range, usually somewhere between 10 and 12. This helps with symptoms without cranking up the risks.
And speaking of risks, you have to be careful with EPO. If you push that hemoglobin too high, you can actually increase the risk of really dangerous blood clots, both in the veins and arteries. It's a very delicate balancing act.
So let's bring it all home. Why does this matter so much? Because if you mistake anemia of chronic disease for a simple iron deficiency, you're going to give the wrong treatment. Giving iron to someone whose stores are already full isn't going to help. The absolute key is to recognize that pattern of trapped iron. That's what leads you to find and manage the real underlying problem.